Hello everybody, this is part 2 of the lecture Cardiac Arrhythmia Mechanisms. We will now be exploring arrhythmia mechanisms of bradycardias and heart block. These are the objectives for the medical cardiology rotation for medical school. We will go through each one in order. So here's a breakdown of the different arrhythmias. This is a flow sheet that we've made to try to explain those arrhythmias better and categorize them. So arrhythmias are either bradycardias or tachycardias. Today we're going to look at bradycardias mainly, and those are either related to the sinus node or to the AV node. So we'll explore those in sequence. A bradycardia is defined as any rhythm with a ventricular rate of less than 60 beats per minute. So any rhythm with a ventricular rate of less than 60 beats per minute, or when you feel the pulse of the person, it's less than 60 beats per minute. The symptoms are usually fatigue, shortness of breath, lightheadedness, which we call presyncope, loss of consciousness, which is called syncope, or potentially death. One of the objectives is to describe the general and specific mechanisms of bradyarrhythmias. There's two main mechanisms of bradyarrhythmias. Number one is decreased automaticity, which is a disorder of impulse generation. The second is conduction block, which is a disorder of impulse conduction. So, like we spoke about in the first part of this lecture, cells within the conduction system have an automatic component, meaning that they have phase 4 auto depolarizes so that the cells will depolarize, leading to an action potential, and this is what drives the heart rate. So the sinus node, the AV node, and the hypercapnic cells will all have the property of automaticity. Now, if for whatever reason there is reduced automaticity, this will lead to a slowing of depolarization of these cells and will lead to a potential decrease in heart rate. Decreased automaticity can be caused by multiple factors. This includes disease of the sinus node, disease of the AV node, or medications, for example. There's multiple things that can lead to decreased automaticity. The second cause of bradyarrhythmias is a disorder of impulse conduction, so conduction block. So even if the automaticity is normal, there could be an interruption of depolarization within the conduction system. This could occur at the level of the AV node or below the AV node at the His-Purkinje system. So identify two electrical structures of the heart that can account for bradycardias. These are the sinus node and the AV node. Both could be susceptible to either conduction blocks or automaticity, or reduced automaticity. So we break down bradycardias by either being caused by a problem with the sinus node or being caused by a problem by the AV node. We'd already discussed the symptoms of bradycardias. Let's first discuss those bradycardias relating to the sinus node. There are 4 types: sinus bradycardia, sino-atrial exit block, sinus pauses, and sinus arrest. Now, a note about sinus bradycardia. In athletic people, or during times of sleep, for example, during sleep we have a very high vagal tone. A person can have sinus bradycardia which is completely normal. So it's normal for an athlete to have a heart rate in the 50s or even less, and normal to have a resting heart rate during sleep that may drop down to the 40s or 50s, and that would not be categorized as an abnormal rhythm. It would be sinus bradycardia, but it's a normal expected physiologic response. But sinus bradycardia could also be abnormal. For example, if the person is walking with a heart rate of 50 or 40, or trying to exercise or run and the heart rate does not go above 60, that's abnormal. So it really depends on the condition in which the person is in. So if they're resting or sleeping, it's normal to have a low heart rate, but with activity, there should be an appropriate response. So sinus bradycardia is defined as sinus rhythm with a rate of less than 60 beats per minute. That means that the sinus node is pacing at less than 60 beats per minute. And here we see that this is still sinus rhythm. There's a P wave before every QRS, there's QRS before every P wave, but the sinus rate is less than 60 beats per minute. So this is sinus bradycardia. The P waves will have a normal axis because they're still coming from the sinus node. So the P waves should be positive in leads 1 and 2. This is the second condition relating to the sinus node, and it's called sino-atrial exit block. So here what we see is there's sinus beat, a sinus beat, a sinus beat, and so on. And then there's a sinus beat with no beat following and another sinus beat. And if we measure this interval over here between these two QRS complexes, or these two P waves, is double this interval. So if you set your calipers to this interval, you'll find that it's double this interval, meaning that there's a P wave here that blocked. So this is sino-atrial exit block, and this is a problem with impulse conduction rather than automaticity. Whereas sinus bradycardia is a problem with impulse automaticity or decreased automaticity. This here, there's a problem with impulse conduction. There should be a P wave here, but there must be a block within the sinus node or outside the sinus node that prevents it from propagating to the atrium from the sinus node. This is an example of a sinus pause. So here, there's a sinus P wave with a QRS, a sinus P wave with a QRS, and then there's no P wave for an extended period. So this would be a sinus pause rather than exit block, because there's a prolonged period where there is no P wave, and it's not a multiple of these. So this is a much longer interval. So this is a sinus pause or sinus arrest. So these are the different types. Sinus bradycardia is reduced automaticity of the sinus node for whatever reason. Sino-atrial exit block is a conduction block preventing depolarization from exiting the sinus node to the atrium. And sinus pause and sinus arrest are similar, but a sinus arrest is usually a longer phenomenon. Now we'll move on to AV nodal arrhythmias, or bradycardia is related to AV node problems. So there's first degree AV block, there's second degree type 1 and type 2, and there's third degree AV block. And these are occurring at the level of the atrioventricular node. One note about first degree AV block is that it's not a block or a cause of bradycardia. In fact, it's a misnomer. First degree AV block does not cause bradycardia, and I will explain so in a second. However, I did include it in this chart as it's important to understand what it is. So this is the definition. In first degree AV block, all the P waves are still conducted, but the PR interval is prolonged, more than 200 milliseconds, so more than one large square on the ECG paper. A second degree AV block, some P waves are conducted and some are not. Mobitz 1, there is progressive PR prolongation prior to the blocked P wave. Mobitz 2, there is no prolongation of the PR interval prior to the blocked P wave. And I will show examples in a minute. Third degree AV block, none of the P waves conduct. So in first degree, all of the P waves conduct. In second degree, some of them conduct. In third degree, none of them conduct. So let's look at first degree AV block first. So this is an example of first degree AV block. Here we have sinus P wave. So there's a P wave that's positive in 1 and 2. There's a very prolonged PR interval, more than one large square, so more than 200 milliseconds, and then there is a QRS complex. So this is a prolonged PR interval leading to what we call as first degree AV block. It is a misnomer though. There is no actual block. Every P wave conducts to every QRS. P wave, QRS, P wave, QRS, P wave, QRS. So conduction does take place. It is just delayed. So there are people who feel that this should be prolonged AV conduction rather than first degree AV block, because there is no actual block. Every P wave still conducts to every QRS. In fact, like we said before, this is not a cause of bradycardia. If the sinus node is beating at 70 beats per minute, the QRS complexes will also be going at 70 beats per minute, because every P wave leads to a QRS. So first degree AV block in and of itself does not cause bradycardia, because every P wave will conduct to a QRS. But on the ECG, it is noticed that there is prolonged PR interval, and that's what we call first degree AV block. So one of your objectives is explain why first degree AV block in and of itself does not account for bradycardia. It's because every P wave will conduct to the QRS, hence the heart rate determined by the P waves will be the same rate as the QRS complexes. So if the sinus rate is 70 beats per minute, the pulse will be 70 beats per minute. None of the P waves actually, all of the P waves conduct and none of them will block. Moving on to second degree AV block, here some P waves are conducted and some are not. And what matters is the pattern in which they conduct. So with Mobitz 1, which is called winky back, there is progressive PR prolongation prior to the blocked P wave. With Mobitz 2, there is no prolongation and there is a sudden loss of QRS complex. Now this has some implications which I will discuss in a minute. So why is it important to distinguish between type 1 and type 2? And what are the clinical implications? Well, type 1, which is what we call winky back and involves prolongation of the PR interval, usually occurs at the AV node level. Why is this important? It's because there is no significant morbidity or death with winky back or type 1 second degree. In fact, most of it is quite benign and asymptomatic. So people who present with winky back usually don't feel it and do not need any treatment. However, Mobitz 2 block or type 2 second degree block is different. Here there is no progressive PR prolongation and there is a sudden drop in QRS, and this occurs usually at the His-Purkinje system, so below the AV node. This carries a very high risk of progression to complete heart block, and thus even if the person is not very symptomatic or not having syncope, if it's detected on an ECG, there's an indication for pacemaker implantation, because this could progress to complete heart block. So this is second degree type 1 Mobitz, also called winky back. Here we have a P wave and a QRS. There's another P wave and another QRS. You see that the PR is getting longer. P wave QRS, the PR continues to get longer. P wave QRS, the PR interval is even longer now. There is a P wave with no QRS, so there's a dropped beat. So some of the P waves conduct and some of them don't. And then there is return of conduction. So P wave QRS with a short PR interval, prolongation, 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 block. Back to normal, prolongation, prolongation. So this pattern of group beating where some of the P waves conduct and some of them don't, with gradual prolongation of the PR interval prior to the block, is called second degree type 1 AV block, which is also called winky back. The second type is Mobitz 2. So second degree Mobitz 2, and here we have a constant PR interval for all these beats. There is no prolongation, and suddenly there's a drop P wave right here. Another P wave conducts, another P wave blocks. This is second degree type 2 AV block, also called Mobitz 2 AV block, and this has a high risk of progressing to third degree AV block, and thus has more serious clinical consequence. So distinguish between second degree type 1 and type 2 heart blocks in terms of both ECG manifestation and clinical implication. We've discussed it in Mobitz 1, which is winky back. There is gradual prolongation of the PR before the blocked P wave. It is at the level of the AV node, not significantly associated with morbidity or death, and is usually asymptomatic. Mobitz type 2 occurs below the level of the AV node and has a high risk of progression to complete heart block. Here, there is no prolongation of the PR interval and a sudden drop of a QRS complex. So here's a question. What is this tracing? And I will give you a few seconds to interpret. So here, you see a P wave followed by QRS, a P wave with no QRS, a P wave followed by QRS, a P wave with no QRS, and this goes on. So this is what we call 2-to-1 AV block. So for every 2 P waves, there is 1 QRS complex. So is this second degree type 1 or type 2? Well, the answer is we can't tell for sure. Because in order to tell, you need to see if there is PR prolongation between subsequent conducting beats. So you need at least 2 P waves in a row that conduct to see if the PR interval prolongs prior to the dropped QRS complex. Here, we don't have 2 P wave complexes in a row that conduct, so we can't tell if there's PR prolongation. We have one that conducts and one that doesn't, one that conducts, one that doesn't. So in this particular case, we cannot tell if it's type 1, sorry, if it's second degree type 1 or type 2. However, one thing you could do in this case is get the patient to exercise in bed. So for example, do some sit-ups or move their legs around, or get them to walk around and increase the sinus rate. By doing so, you change the conduction properties, and you may get 2 P waves in a row that conduct, and then you can tell if this is winky back or type 2, so second degree type 1 or type 2. But with this ECG in and of itself, you cannot tell. Moving on to the third type of AV nodal block. So this is third degree AV block, which is also called complete heart block. In this case, none of the P waves conduct to the ventricles. The atria and the ventricles are completely dissociated, and there's no connection between the atria and the ventricle electrically. So here you see there are P waves marching through, P wave, 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 and the QRS complexes are marching at their own rates, at their own regular rate, and there is no relationship between the P waves and the QRS. This is called complete heart block, and what we're seeing is an escape either at the junction, the His-Purkinje system, or the ventricular myocytes, where there's an escape to allow for the person to survive, make it to the hospital, and hopefully get a pacemaker to increase their heart rate. This is a 12-lead example. So here we have a P waves marching through, and here's the arrows to show you, and the QRS complexes also marching through at a much slower rate. You see how the QRS complex is quite wide, and this is because this is either originating in the His-Purkinje system or the myocytes. And this is called a ventricular escape rhythm. Ventricular escape rhythm. So here we have a severed connection between the atria and the ventricles, and the P waves are dissociated from the QRS complexes. This is complete heart block. So here's the objectives for bradycardia. Define bradycardia. It's any rhythm with a ventricular rate of less than 60. Describe general and specific mechanisms. So we discussed both decreased automaticity or conduction blocks. Identify the two structures that account for bradycardia. We have the sinus node and the AV node. Describe the two levels of AV blocks. We can have second degree and third degree heart blocks. Explain why first degree heart block does not account for bradycardia. It's because first degree heart block refers to a prolongation of the PR interval, but every P wave still conducts. Distinguish between second degree type 1 and type 2 heart block in terms of both ECG manifestations and clinical implications. So second degree heart block, there's still a link between the atrium and the ventricle. Some P waves conduct and some P waves don't. Type 1 may or may not be normal, and it may or may not require a pacemaker. The vast majority of type 1 second degree AV block, which is also called winky back, is benign and is related to high vagal tone. Type 2O is always abnormal and usually requires a pacemaker because it can progress to third degree heart block. Recognize third degree heart block. There is no link between the atriums and the ventricle. This is always abnormal and requires a pacemaker.